Yeah, my name is Inga Drossart. I work for the German Heart Foundation, and I'm also a NOAC patient, or used to be a vitamin K antagonist patient for 8 years and then switched to a NOAC. So I can relate to everything you're going to hear about the problems and concerns our members bring to our attention. Just a short overview. I will give you some background on the German Heart Foundation, because I know many of you are not German and might not know what we are doing and who we are. I want to briefly talk about, in general, about the concerns and problems that are brought to our attention and related to NOACs. And then I want to go more into detail about what we know about patient preferences and their values, and I thought the best way of doing this would be to show you some cases, show you some questions that we get in our everyday business, and and then I will have some conclusions from that. So German Heart Foundation is a non-governmental organization. It's a non-profit organization that was funded already in 1979. So we are nearing like 40 years. We currently have about 96,000 members. We are hoping, and we're quite certain that we will reach the 100,000 mark this year, because there has been a very steady growth of memberships. Our main income sources are the membership fee, which is at least €36 per year. But we also receive a lot of donations. We receive legacies. People even leave us their houses when they die. And what is very important, we receive no funding or any other support from the industry. So we're, in this regard, a totally independent patient organization. We can be critical of things and have been critical of certain treatments in the past already. And I think this is important to point out, because nowadays many patient organizations just don't survive without any funding from industry. And we are making it, and it's sometimes tight, but it works. We have about 32 people working in the Frankfurt office, which is not a lot when you look at the member numbers, but I think we're doing quite well. So what do we do? Basically, what we do most is empowering patients, and this is the motto is knowledge is power. We help patients understand their diagnosis. We provide them with up-to-date information on their treatment options. We educate them and also the general public about benefits of a heart-healthy lifestyle. For instance, we promote the Mediterranean diet a lot. We always encourage patients to ask questions when they go to their appointments. We encourage them to write the questions down, to take someone with them. We encourage them to get a second opinion if they have facing a big surgery, or if they don't trust, if we think from what they tell us, they don't really trust their physician. I always tell them, okay, you have the option to get a second opinion. Maybe that's something to do. We offer advice on how to find a specialist. We don't give specific recommendations, which is also for legal reasons, but also because we cannot know every clinic, every physician in Germany. So basically, we are encouraging them to become their own advocate, to take responsibility in their treatment as far as possible, and with the message being, keep an eye on your heart. How do we do that? We have a website, of course, with lots of articles on different heart conditions. We have a monthly email newsletter and a members journal that is published quarterly, and all of our members get this, but also the many clinics and doctors' offices have it so that patients can pick one up. And it usually covers very recent topics. For instance, in the current issue, we have a big article about the life vest, because this was brought to our attention by several members. They were asking questions about this, so now we have a big article on it. We have lots of information materials, different brochures on coronary artery disease, high blood pressure, on arrhythmias, and we also have little neat things to have, like emergency certificates and identification cards, for instance, for people with a stent or endocarditis prophylaxis. We organize seminars and lectures with a focus on November, which is our Heart Weeks month, and we have about 1,000 events nationwide. Every year we cover a different topic. This year it will be heart failure, and there will be a new brochure released for the Heart Weeks with the latest information on treatment options. What I will now go into detail more is the medical consultation service. This is where I work at the German Heart Foundation. Our members, but also anyone else who has a question, can turn to us. They can ask medical questions regarding the diagnosis, regarding the treatment, and they can do that in different ways. They can fill out our online form. They can send us a letter. We still get quite a few handwritten letters by elderly patients. And they can send us an email, and once every month, first Wednesday, they can even also call us. We have a telephone hotline once every month where we have about 12 experts in the hotline, and then patients call us. They tell us what kind of topic they would like to ask a question on, and then we forward them to the appropriate expert so they can actually talk to someone. We, of course, don't give very individualized specific recommendations. That is not possible due to legal reasons, and but we can give them some general advice and hints and tips. So since we are covering all issues in cardiology, this is, we don't do statistics every month, but this was done last year. This is just a request we got via the online form. And you can see, I was asked that already at breakfast, whether atrial fibrillation is a topic for us. It is a huge topic. It is actually, at the moment, the hot topic. Most of the questions we get are related to atrial fibrillation or other arrhythmias, but mostly, I would say, from these 44%, about 80 to 90% are atrial fibrillation, and then about half of it is on anticoagulation and atrial fibrillation. This is some general concerns and problems related to NOACs that are reported to us via this medical consultation service. This might not be big news to you. The concerns about bleeding is much, much greater than the concern about stroke. So we have many, many patients telling us that they are afraid of bleedings. We also have quite a few patients turning to us because they suspect some kind of drug interaction or side effects, especially during the winter time when people have a cold. They turn to us very often and ask, what can I take? Because many NOAC patients have been told, this is what we see, they cannot take anything like ibuprofen, or so they want to know. They have been told this is absolutely forbidden, not even once. Some GPs are very strict on that. And so during winter time, we have lots of questions on this. What is also a big issue is procedures. People facing a tooth extraction, facing a colonoscopy, facing some kind of surgical intervention. And it is not that they ask us first, usually, how to manage the NOACs or other vitamin K antagonists. It is more that they have asked their GP, their cardio, the surgeon who is going to perform the intervention, and they have gotten different answers on what to do. And so they are confused, and it's never good as a patient to be put between several doctors who don't agree, especially when it comes to interventions that have a bleeding risk. I can tell you from my personal experience that last year I wanted to get wisdom teeth extracted, and after seeing a dentist and two dental surgeons, I ended up at the university hospital because nobody was willing to do this in his office on anticoagulation or without bridging. One dental surgeon was even suggesting to bridge, and he was also suggesting to give me antibiotics, which is also, I don't have any indication for that. So I ended up at the university hospital, and they were like, oh, a NOAC, okay, no problem. You know, just skip the morning dose and we will be fine. So that was okay, but it took several visits, and it was not very encouraging to hear all this false information from dentists. We also have patients, of course, that question their indication for anticoagulation, or they question also the dosage. Generally, they like to be on the lower dosage because they think it has a lower bleeding risk. Or they think in atrial fibrillation, they think they could do with aspirin only. They turn to us and say, you know, wouldn't that be enough? Or can I just take the NOAC when I have an episode? Or they just don't feel comfortable taking it all the time. And it's mostly because of the first point I mentioned, the bleeding risk. What we sometimes see is the triple therapy problem. Because those patients, they simply question whether this isn't too much. They see all their drugs and they see 3 anticoagulants and they just think it's too much, and they question whether this is really needed. And then last but not least, we also see that patients often voice their preferences, but they don't always get what they want. They are denied their preference because of different reasons that I will go into a bit later. And this is often also a reason to turn to us and to ask us, you know, how can I convince my GP or my cardio to give me the anticoagulation that I feel comfortable with. I have here just to show you about the problems and concerns that this is not just what we hear at German Heart Foundation. I have another slide. This is actually, it's from a Facebook group. It's an atrial fibrillation support group on Facebook, where you can put also up some polls. This is an mostly American group. And I just wanted to double check whether the questions we get correspond with what is being discussed in groups like this. And there you see the bleeding risk is the issue. You know, antidote is an issue. The drug interactions. So basically, it is in line with what we see. Someone mentioned from the American side mentioned that the bleeding risk perception in the US might be even higher because of all the lawyers at the moment working on that lawsuit. And in the US, it is they are allowed to advertise for this, and so people are being more alert of it than in Europe, maybe. But let's go back to the preferences, and I have a few, as I said, a few case studies, if you may say so, prepared on typical questions that we get. This is a member very well known to us. She asks more often. And she's actually also quite well informed. She says, I have some procedures in the future, and I've heard the whole management is easier with NOACs, so I'd like to switch from a vitamin K antagonist to a NOAC, in this case, Eliquis. And and she's actually questioning the dosage because of her twin sister. We don't know anything about her twin sister other than that they are, of course, the same age, but no other information. We don't know. I mean, she is, her weight is quite low, but we don't know about her kidney function. So this is one of the questions that has been, where she got, so we have different ways of answering questions. This has not been forwarded to an expert because we have an article on Eliquis that explains who can get that also explains who can get the lower dose. And then we can send her the article and we can ask her to discuss this again with her doctor and ask him about her kidney function. But for her, the procedure management was the reason why she wants to switch. And this is a caregiver, actually, asking for his mother-in-law. She is complaining about the INR tests, and they have asked the GP, they want to switch her to NOAC, and he refused, arguing there is no antidote. And this is actually something we hear often from the physician side. Which is quite bad, I would say. And then he thinks it might also be because of the age, but I can tell him we also hear that about younger GPs, telling their patients, oh no, there is no antidote, but for the vitamin K antagonist, we have one. And so it's misinformation. This is a question that we will probably, I think we have sent to an expert, and then he's going to explain about, antidotes and all that. Not everybody wants to switch to a NOAC. It's a big surprise, although it's so much easier. But we do also have patients who are doing very well on it. I mean, this patient he had an INR of 3.1 once. He was doing well before in the INR. I mean, he wasn't like 4 or 5, it was 3.1, and now the GP says, you need to switch. And he was fine on that. He's feeling, or his son thinks he's feeling more secure when he's being seen regularly. So he's questioning whether his father really needs to be switched to a NOAC. And this is a good question. I mean, the current recommendations, if you do well on a vitamin K antagonist, are not saying that you need to be switched. So, so this is also something to forward to an expert. Here we have a patient with coronary artery disease. Had his first episode a year after the stent was placed. Usually he doesn't have very many episodes, only every 2 years or so. So far has not been advised to take any anticoagulation except for aspirin, but he needs to take that anyways because of the stent. But now something changed. He had his last episode beginning of this year, and all of a sudden the cardio says, now you need to switch. Now I want you on a NOAC. I don't know why he wants him on the 30 milligrams. We don't know, but this patient says about, when it comes to preference, he says, I have a very active lifestyle, and I mountain bike, I ski, I hike. I am very afraid that when something happens, I'm afraid of the bleeding. And this is also something that we hear quite often from those patients who are still physically very active, also involved in contact sports, for instance. They are afraid what happens when I get hit, what happens when I fall while mountain biking. And in this case, the score, he provided additional information. His score is 1. Can probably be debated whether he really needs this NOAC. And last but not least, this is again a patient having trouble staying in the INR range, but has been suggested to switch, but then has, as we would say, done his homework, tried to get some information, and he has read some very bad things about Xarelto, and actually, if you live in Germany, you know what this TV documentary was last year. Actually, whenever something is in the media, next day or so we get the questions. Happens all the time. And people follow what's being published and what's being shown on TV, and then and then you get the questions. We are still dealing, last year in October there was a documentary on statins. We are still dealing with that. It has a huge effect. One should not underestimate that. So, what you see from all these examples is patients have values, they have preferences, they report various reasons for their choice, like convenience, like difficulty staying in the INR range, like their lifestyle, like media, and sometimes they also report that they have to go what their physician would like to see. We had patients complaining about physicians not prescribing NOACs because of the costs, but it was a lot more a year ago. It has subsided a little bit. What follows from this is they have concerns, they have their preferences, and what we think is this needs to be taken into account. If we are talking about increasing adherence and also enhancing patient safety, we need to talk about about the fears, about the concerns. We need to listen to why they feel more comfortable with one over the other drug, and then what we also see is, of course, we need a better education, especially about bleeding versus stroke risk. I think a lot more can be done. And our experts are already into this and explaining a lot and trying to calm everyone's nerves. But I think more could be done in this regard. And it's not just the patient side, it's also the physician side. We also need a better education and also cooperation when it comes to procedural management. We very often hear that the cardiologist is not talking to the surgeon who is doing the intervention and so on. And then this happens, that the patient gets in between, and this is really the worst. And we also need better education with regards to the indication and dosage, because we do see patients not receiving any NOAC who should, according to the information they have provided us with, be on a NOAC or on a vitamin K antagonist. We have patients receiving the lower dose where we don't know why. We also have patients not receiving the normal dose, but should be on the lower. So, and we have the whole debate about when to anticoagulate. We have some patients with a low score who are questioning whether they really need to be on this drug.